Welcome and thanks for coming. These two groups of disorders that I'll be discussing are certainly far less common than the three groups we've heard about, and that's the CNS system disorders of GI pain and the functional biliary categories. But they are very important because obviously patients with these disorders may be subject to far more invasive investigations and even far more invasive treatments, including surgery, than the other disorders we've heard about. But I'll be a little briefer than the other speakers. For these categories, Peter Warwell is the chair and Laurie Kiefer the co-chair, and the members as listed. And this umbrella term, central nervous system disorders, as Doug said now, encompasses the functional abdominal pain syndrome and the narcotic bowel syndrome, NBS being the new addition, and obviously more common in fact than the FAPS. One might say there's been no major advances in the functional abdominal pain syndrome, but that doesn't mean there's not been a lot more to discuss in this chapter, not only because the addition of narcotic bowel syndrome and opioid-induced constipation, but also because of really quite a lot more information regarding the neural aspects of pain and an increased understanding of various psychological processes involved in the whole overall pain experience. Just to look at the possible proposed or new diagnostic criteria for this difficult entity of chronic functional abdominal pain, or FAPS. These are similar to the previous criteria, in other words, the presence for at least 3 months of continuous or nearly continuous abdominal pain, and this is usually of a more severe degree than, say, irritable bowel syndrome, and particularly no or only occasional relationship of pain with the physiological events that are so closely associated with the other disorders that we've been hearing about. Together with loss of daily functioning and the pain not being feigned or not deemed to be being feigned, and the term malingering has been removed to take out the pejorative aspects that surround this whole difficult syndrome of FAPS. And of course the pain not explained by another gastrointestinal disorder, and this of course raises the issue of how far does one go in the diagnostic workup. And as I said, patients are subject to and a continuing increasing array of diagnostic tests, and the committee are making recommendations perhaps on how far that should extend, although that's difficult for the individual patient, of course. Narcotic bowel syndrome is the interesting new disorder included in this chapter, and of course we recognise this far more frequently now, or we should be, with the massive increase in the use of opioids for non-cancer related pain. And one definition is chronic or frequently recurring abdominal pain treated with acute high dose or chronic narcotics and 2 or more of the following. You can read them there, and needn't go through those. The third one there is progression of the frequency, duration and intensity of the pain episodes, and particularly the nature and intensity of the pain not being explained by a current or previous GI diagnosis. And this condition, of course, can occur in patients with structural disorders such as IBD, even chronic pancreatitis, etc. But perhaps even more difficult is when it occurs in a patient with perhaps a pre-existing functional syndrome. So what are the changes from Rome 3? I've alluded a little bit the addition of the section on narcotic bowel syndrome, and what we think will be helpful for clinicians is some discussion on how to identify drug-seeking behaviour and opioid abuse. Some expansion of the doctor-patient relationship section, so important in this group of patients. Once again, a much greater expansion of the psychological assessment, how to do this, when to do this, and also enhanced treatment sections, and a significant focus on neurogenesis, neuroplasticity of the pain, which is one of the increasingly relevant areas. So they're the main changes for FAPS and the introduction of NBS.
I'd like to make one clarification on NBS. The bowel chapter is handling OIC and OBD. So remember, there's the effects of opioids could be peripheral, where the pomoras would come in on new opioid receptors. It's causing constipation or nausea or vomiting or those things. But we're talking about a central hyperalgesia syndrome, which is only about 1 out of 20 patients with OIC, and that's why it goes in here, because the treatments are going to be more central.